Okay. Hi, everyone. Welcome to our first kitchen table of the year. This is Lucinda Canty from Lucinda's House, and today we're going to talk about infertility. So infertility is not my specialty, so we have some experts here, but I also have some members from the collective that are here as well to offer support and insight as well. So we're all going to introduce ourselves and we're going to jump right into our topic. So I'm going to start with you, Lakisha, if you could introduce yourself.
Sure. Hello, I'm Lakisha Rivera, and I am a nurse and nurse midwife. I work at Women's Health Connecticut as a director of clinical operations. Women's Health Connecticut is a management system organization for most of the OBGYNs throughout the state of Connecticut. My role in that position is not clinical, it's administrative. So a lot of what I say is paper pushing, policies, procedures, consents, supporting the practice managers and the providers to provide care for our women. And as far as me knowing Lucinda, I first knew Lucinda from working at Hartford Hospital. And then a few years that we kind of didn't, see each other, but then started coming across in different webinars and conferences. And now I am in support of, but she's also low-key, never said this, but she's a mentor for me too, as far as many people I know. Very inspired by her work, research work, her presentations. I always try to make sure if I see her name as a panelist, I am signing up for it. Sometimes I don't even really know what this conference is about, but if I see Lucinda's presenting, I'm like, I gotta go, I'm there. But that's how much I admire you, Lucinda, and, support. And again, like she said, I'm not an expert in infertility, but obviously working in the OBGYN fields, come across this quite often. And I'm really excited about this conversation.
Yeah, thank you. Thank you for that. Roseanne?
Hi, my name is Roseanne Richards, and I'm a family nurse practitioner. And I currently work at Hartford Healthcare in general surgery and hand surgery specialty. However, I'm not an expert in infertility either, but I do on occasion speak to a lot of our patients who feel comfortable confiding in me, and sometimes I can offer them referral or just support, giving them some extra information on the topic and other topics that they might be interested in. I know Lucinda from University of St. Joseph's. She was my women's health professor. She was a mentor to me there as well, and still is. And I work with her at Planned Parenthood as well. I'm passionate about supporting women's health issues. And I'm also passionate about reproductive equity. And that's it. Thanks.
Thank you, Roseanne. Trashaunda?
Hi, my name is Trashaunda Brown, and I'm a reproductive advocate. I work at Infertility. I'm the Director of Provider Network Engagement. My role there is to work with the providers and help WIN expand their network to ensure everyone has access to reproductive care, whether it be through their insurance, a health plan, their employer, or it's an out-of-pocket cost. And previous to that, I worked in the IVF facilities, giving me access to all aspects of the process. I'm not a professional as far as being a nurse and or a physician, but I have tapped into the entire process and I use that information to advocate to the community. I met Lucinda through Casey. They invited me to her community baby shower, which was beautiful. It was an event that everyone was engaged in and very supportive, and it was educational and it was welcoming. And at that moment, I knew I wanted to continue to connect with Lucinda, and she has been nothing but receptive of that and allow me to join this session here today and talk to the community about a common interest we have.
Okay, thank you. And there's more information also on the website, and we'll talk about that as we're going through our conversation. Heather Harris.
Hi, my name is Heather Harris. I'm a family nurse practitioner, and I mostly focus on women's health. I currently work for Hartford Healthcare at an OBGYN clinic, and I know Lucinda as a mentor as well. She's been challenging me and supporting me and guiding me since University of St. Joseph, and then also worked with her at Planned Parenthood. So I'm excited to have this conversation. I think I get to talk with a lot of patients about fertility and women's health issues. I'm also excited to be with other Black professionals and to hear what is also available for patients and just resources for me to know about as well. So I am happy to be here.
Thank you. And Thelma.
Hello, my name's Thelma. I'm a family nurse practitioner, but I currently work in fertility. I work for Illum Fertility as a nurse practitioner, and I love the place. But yes, so I know Lucinda from Planned Parenthood because that was my first job as an MP. I worked with her for a few years, and she was great. Always looked out for everybody and was such a good person. But yeah, at Illum Fertility, it's run by reproductive endocrinologists, and we offer fertility treatments, diagnostics, and help people get pregnant. So what I do mostly at Illum Fertility is we do a lot of the morning monitorings. Like if a patient is going through IVF or IUI cycle, we kind of monitor their follicle growths every couple of days until we get to the stage we're supposed to do to go for the next stage. I also do part of the diagnostic process of the saline sonos and HSGs. The HSGs are just like they're x-rays of your pelvis, and we kind of flush dye through it to make sure that the fallopian tubes are open and patent. The saline sonos are just a test that we do to evaluate the endometrial cavity, make sure there's no like polyps, scar tissue, or fibroids that affect implantation. But yeah, I'm excited about this conversation to see what we can get out of it, and then to see if we can help people too as well.
Thank you. Thank you all for being here. But let's start with what is infertility? And Trashaunda, I'm going to ask you because you have a long history in this area.
Thank you kindly. So infertility is the inability to produce a viable egg and or sperm over a period of time. Based on your age, the time frame can change. If you are 35, it's a year. Anything above that is a 6 months time frame. So essentially, infertility is the inability to produce a viable sperm and or egg to conception.
Okay. And why is it a conversation that we don't often have in the Black community? And I've learned in other communities of color as well. How come we don't talk about it? And I'm going to start with you, Roseanne.
I think that there may be a stigma surrounding it in the Black community. A lot of times we don't really talk amongst ourselves as women about struggles that we face. We might suffer in silence or feel like we're alone in struggles that we're going through.
Yeah, and I just want to share that even for myself as a nurse midwife, I never thought about infertility. I just felt that when I was ready to get pregnant, I would get pregnant. And I realized that when I did want to try, I couldn't get pregnant right away. And I was in an environment, I was working in an environment that I considered toxic. And when I left, I was looking for another position. I became pregnant in that transition. So I'm like, maybe you did have some infertility issues, and maybe it was because of where you were working. But I just realized I just never thought about it. And Heather, why do you think that is?
I mean, your health has a lot to do with it as well. And so stress is a major factor on your health and your immune system and how your hormones are regulated. So if you're going through traumatic events, if you're going through stressful times in your life, I mean, not only is that going to affect your immune system and how well you recover and heal from illnesses, it's also going to affect your reproductive system as well.
Yes, and Lakisha, were you gonna say something?
Yeah, I wanted to say too, or ask as well, you guys can jump in, but I often heard that there's a level of embarrassment too, that women are feeling. They feel embarrassed that they're having this, infertility, because of A, I'm a woman, I should be able to do this, what's wrong with me? B, if women are married or not, or the man is married or not, but it's family or friends, when you're gonna have children, especially when you do get married, when are you gonna have kids? When are you gonna have kids? And that pressure, so they feel embarrassed to say anything. So I mean, if you guys can jump in too, but I feel like that sense of embarrassment is one part where why the women themselves or men don't say anything to their providers, or it's not talked about amongst each other in the community, to get some support or ask, hey, you guys know of a place or a doctor I can go to. So I feel like that in of itself, we need to figure out how to make them comfortable, make people comfortable to talk about it more, and let them know, like, yes, there's resources out there, but if they don't ask, how will they know?
Mhm, mhm.
And I just want to add too, even when women go to their well woman visits, that could be a perfect time for provider to bring the topic up, asking them about are they thinking about family planning, like what are their thoughts and so forth. Because even the stigma sometimes or general consensus is that if there's a fertility issue, the woman is the problem, and sometimes it's the male who might have the problem.
Yes,
I was
and
going to add on to that too, like Lakisha said about the embarrassment and Roseanne said about stigma, is that it's not because there aren't a lot of conversations about it. It doesn't seem like it's commonplace. I have some patients who come to me thinking that something's wrong with them, or that they've done something wrong. And that's a hard thing. If you're thinking that way, that's a hard thing to settle with, to live with, and then let alone ask for help, or even talk about it when it seems like nobody's talking about it or it isn't happening to anybody else.
I would like to add to what you're stating. I agree with all of you ladies, and just to tail on to the embarrassment, I think in our demographic, a lot of it has to do with culturally, about what's expected for an African American woman to be able to do the same for an African American man. And then to add to that, there's a lot of people who make decisions based on religious factors, and then that can be a barrier to someone proceeding. I'm embarrassed, and how can this also mesh with my religious beliefs without making it to something more than what it already is for me personally?
yes, and I know, Thelma, you talk a lot about the male perspective, that we have to consider the male. Why should we do that?
Because there's a lot of things that, so most of the time females think that the issue is related to something related to their like anatomy or something that they did. But most of the time, a lot of the time, I think I don't remember the exact percentage. It might be like 30 to 40% of the time. It's like the male component. Like there's things like steroids, testosterone that could affect their production of sorry.
The sperm?
Their that could affect their production. So that can play a role too, because you have to have a good amount of total motor sperm count. And there's a lot of factors that go into the semen analysis to determine if it's if it's an acceptable level. So they have to take all that into consideration as well.
Yeah, and I think providers also have to educate themselves. I realize, like looking back in nursing school, it was always made to seem like the Black woman gets pregnant easily. She'll
Yeah.
have a lot of pregnancy, she'll have a lot of kids. Even I remember we were talking about creating environments where people felt comfortable getting care, and they were like, well, we have to have daycare because they have a lot of kids. So it's like you keep hearing that message, so that if you do think something is wrong, you're not thinking infertility. And so, and I just feel like as providers, if we educate ourselves and we know anyone could be impacted, some statistics are saying that it's more women of color who are impacted. So I kept seeing like contradictory research on that. So I think we don't really know the numbers because we're not really asking and assessing. But I know in the patients I provide care to, I would say 9 out of 10 times when I find out about infertility is because I'm asking, because they're telling me, oh, my periods are irregular. Then we start talking about, well, have you ever been pregnant? And then that's when those questions or issues come up. So we find out that way. But I think that if we don't ask also too, who we take care of, they're going to think is not important or there's nothing wrong with me. And one other thing is patients who are afraid because they don't want you to tell them that something is wrong with them. But, I can't tell you how many times I found out about thyroid issues, and that was causing their infertility. So I think we have to create that scene where people are able to talk about it. Yeah. So Heather, because I know you provide pretty much like primary care, women's health care. So when should someone talk to you if they're concerned? Or how does that look when you find out there's a problem, that a possible infertility issue?
So I think my patients come to me at various phases, either after a long time of frustration or because they have such irregular periods. I think the best time to talk to a provider about it is when you start having your periods and you're sexually active, just to find out what's a normal period. And what does that mean? Are you ovulating? Are you having a regular cycle? And that, I think, should be a conversation that happens even if you're not trying to conceive yet. It's just an education piece on this is what it means when your reproductive system is working either efficiently or not efficiently. I do talk to my patients like in their well woman visit. I try to be open ended with my questions about their period. So I'm just like, tell me about your period. And then what are your pregnancy plans? Are you trying to avoid it? Or are you trying to get pregnant? Are you planning to do this in a couple of years? And so I like to start the conversation then. That's, you should, if you're thinking about it in the next year, start tracking your periods. We talk about ovulation, what types of changes to expect with that. I do agree with you, Lucinda, in that most of the time my infertility conversations start just from a patient telling me about their irregular periods. Occasionally, I have someone who comes to me specifically for infertility issues with not getting pregnant, and they're pretty frustrated at that time. I usually try to say, even if you're under the age of 35 and it's been 6 to 9 months and you haven't been successful, I'm happy to do a workup. I can run blood work. I send you for an ultrasound. For Black women, I try to find out, do you have fibroids? Do you have a family history of uterine issues? I think there's no reason that I have to wait till 12 months or the year. And if they're over the age of 35, then I might be a little bit faster with it and referring them somewhere else. But I do try to at least, like you said, check for a thyroid disorder, check for any other type of hormone imbalances. And that's something that's very quick to assess in a well woman visit. So as soon as you're coming to me for your regular annual checkup, I'm ready to talk about it.
Okay, nice. And I like how you give a timeline because people don't know how long they should try for. And I like how you mentioned women over 35, that you move faster, they can move faster in the system. But what if a problem or a suspected problem is identified before they could get to Thelma, they have to look at their insurance. And Trashaunda, I know you do a lot of work with that.
Correct. So since we're in the state of Connecticut, I will say Connecticut is a very pro-reproductive justice state. They make sure they implement policies that support the community. So with that being said, Connecticut does have a state mandate, meaning that people have access to reproductive services such as ovulation induction cycles, intrauterine insemination, and in vitro fertilization. So if they do meet with their physician and it is discovered that they have an underlying condition and they're referred to the REI, there are mandates in place to assist them down their path for treatment. However, a lot of people are not familiar with the verbiage or what questions you should ask when calling your insurance company to make sure the coverage is accessible. Just because the coverage is there doesn't mean there aren't prerequisites required for you to access that coverage. So I'm available to help people distinguish their coverage, the time frame, and the language in reference to reproductive health. But there are a lot of insurance policies in our area that support people proceeding with reproductive treatment.
Nice, nice, because it came a long way, because I remember nothing was covered. Even to
Exactly.
say infertility workup, like women didn't have any options unless they paid out of pocket. And the cost was crazy, was crazy. It was no way that you could even like save up. I remember a woman used her income tax check to cover some treatments, but it was like we didn't have insurance as an option, and that was a challenge. But yes, but what if someone doesn't have insurance?
Perfect. I was going to add to that. People who don't have insurance, there are numerous foundations nationwide that provide grants, that provide financial assistance to ensure you can proceed, whether it's for the treatment, there's grants just for the medication. There are grants that are custom based on your religious beliefs as well. There are grants accessible based on your sexual preference. So there's all options available for each individual if they want to move forward. You could just do your research, or if not, I'm sure any one of us here are happy to help people.
Yeah, and I'm glad that you mentioned there's a variety, because I remember talking to lesbian couples because they're wanting to have children. And again, not knowing what their insurance will cover, would their relationship even be honored. So it's nice to know that those are available as well. And I think it still is to ask that question, are you thinking about pregnancy? And I want to say, Heather, I love how you weren't like, when are you going to have a baby? Or, you're too young to have a baby, so what are you going to use for birth control? Like having those assumptions, because I think that shuts people down. But I like that question. Are you thinking about it? Are you not? Because it gives them that option and makes them feel safe either way. But I think it's important to ask our same-sex couples that same question, because then it seems like there's options available for them as well.
Correct. So as I mentioned, we do have the Connecticut mandate, and I'm glad that you brought up the same-sex couples because the coverage is accessible, but same-sex couples may not have access to it because the female has not been exposed to sperm. So technically, she's not really infertile, it's a choice. So the insurance company will then not cover that treatment. So that was an amazing point that you brought up, Lucinda. And then at that point, those couples can then utilize the grants from certain foundations that are available.
Okay, okay. Oh, that's good to know.
That's good to know. I didn't even know that. I had a little like question that maybe Heather or Lucinda, someone can suggest. So Heather, you were saying that you as a provider, you start the conversation with the women. So I have a piggyback question. What if the provider doesn't start that conversation? Because I do know for a fact, there's some providers who schedule their annual appointments 10, 15 minutes. So what can really be said and assessed in that short amount of time? And how in depth can they get into asking the important questions that you stated you ask your patient? So as a patient, how can she advocate for herself, or, what starting out if she doesn't know to say, okay, my periods are this, that, and the other, and not knowing if it's regular or irregular. And yes, I do want to get pregnant in 2 years. What are my options? You know what I mean? So how does a patient start that conversation if their provider does not?
Yeah. Go
That's a
ahead.
great question too. I think, I mean, I think some clinics and practices are more open to these fertility consultations and preconception consultations. And then again, you have the same question: how do you know that you need to call and schedule to ask for that? I think it's a responsibility of the clinic and the practice to at least have it accessible on their website to say, hey, these are the types of things we can talk about. You don't have to come in for an appointment because you missed your period or because you need a pregnancy test. You can come in for an appointment to talk about you're planning to get pregnant in a year. What do you need to do? Or you think something might be off with your periods, but you're not sure. Those annual visits, timing is tough. I'm not going to lie. I think I've worked at a few locations where they try to give you paper forms to fill out in the beginning of the visit that gives you a section to talk about what your periods are like, or if you're having any contraceptive questions or concerns. It's a step in the right direction. I don't know that we really capture a lot with that, but I'm hoping that if I can at least mention something about it or get the woman thinking that, hey, oh, if you're not having a regular monthly period and you have some family history of other things going on, maybe you should come back and see me or see someone and we should talk about it. So that's where I'm at with helping getting
So,
women to talk
I
about
have to start a little trouble. Good trouble. So when you go in for your annual visit, it's a health screening visit, and this is part of your health. And especially in whether you have insurance or not, somebody's paying for that visit. That visit is covered for you to be getting holistic care. Because a lot of places will claim, or we'll take care of you and all your needs. And then you come, they're like, oh, just give us one problem. That's not how you provide health care. And you have that right. Because if it was the same for everyone, and we know some patients get more time than others, you have the right during that visit. It's not your fault that they schedule 3 people at the same time, or they schedule you 15 minutes because your insurance is covering for a whole visit. So when you come in, I think, especially if you're there for an annual, if I'm already doing testing for glucose, for diabetes, if I'm checking you for anemia, if I don't know that you have concerns about infertility, I may not do that thyroid test. So why should you come back and have another visit just to do your blood work? So my plan of attack, when you go in for your visit, have your questions ready. Because sometimes things happen so quick, you have questions, but they're like, you have any questions? And then when you're trying to think of it, they're like, okay, well, I'll see you next year. So say, yes, I have some questions. Get your phone. I have people that they use their phone, they write them down. So, and I even say, as you're thinking about this, write down those questions that come to mind. Because even though your provider may not have all the answers, they could say, I want you to look at this online. And then we could come back and we'll follow up more. Or because this is a concern, let me check your thyroid. Why don't you take a record of your periods, or go home, get your calendar, look at it so we can see if there's a pattern. That visit, you really deserve that. Because especially if you're there for an annual, if you're coming for a problem visit, is a little bit different. Unless they really know that you're coming for infertility, they could make sure it's scheduled that way. But for an annual, ask those questions that you want to ask, because there are things that you can do. And I'm just throwing out some things that could possibly cause infertility. Again, there's things that we still aren't sure about, but like obesity. So I could talk to you about your nutrition. I could have you see a nutritionist. I can talk to you about exercise. Like, those are things you could do. But if I have you during that visit and I'm like, come back next month, or come back in, because we know how hard it is to get appointments. So when you got them, and let that provider try to leave the room on you. You call their customer, the customer advocacy line, because you deserve that while you're there. They say they want us to take better care of ourselves. They need to give us the time. So, but I say, always have your questions ready. Again, I worry sometimes about Google, because Google could take you places you don't want to go, but at least it could give you some questions to prepare and to ask. And then if you have that provider that will say, this is important, I don't know if this relates to you, but maybe we can do a blood test, or maybe you could do this. It only takes a few minutes to do that. And so I think that you have to kind of demand that from your provider. You shouldn't leave with a whole bunch of questions in another appointment in 2 or 3 months. So I just say, just be ready. And also on the website, I just want to say that this is really to help empower you when you go in for your visits. And on the website, we'll have some things that will just help you to ask those questions. One thing is that we don't want to tell you what to do. We want to have you make those decisions and be prepared. And the same thing with your provider. Your provider can't tell you what you need. You need to tell them what you need. So I think that's an important question, but I think that's why infertility is not always addressed, because we're in and out for our visits and we depend on our providers, and sometimes they're not there. And it doesn't have to be because they don't have the time. Maybe they don't know. but your provider will also say, because like for me with infertility, I can do a workup to a certain point. Even Heather, you do more than what I know how to do, but at least I can do the basics, and then I know how to refer out and to make sure that you were safely referred out. So anyways, I'm just saying as a provider, we have a very important role. But I want to ask Thelma, because we talk about infertility, we know there's treatments, and I'm telling you, I'm terrified. If someone is like, go see that infertility specialist, I'm like, what am I going to do to my ovaries? Where am I
Yeah.
going to have my uterus when I leave? So I know there's a lot of fear. So
Yeah.
when they go to see you, like what happens?
So usually when a patient first makes an appointment with our clinic, the first person that they usually come into contact with is the reproductive endocrinologist, like the doctors. And they kind of take a clear history, like involves like, you know, how long you've been trying to conceive for, any other disorders. One thing that most people don't know that they have is PCOS, which is polycystic ovarian syndrome. And that's a common cause for infertility, especially in like the younger ages, because you basically don't, like if you're having a period every 6 weeks or every 3 months, that means you're not ovulating regularly every month. So how are you supposed to get pregnant if you don't know when you're going to ovulate? It's kind of like hard to, you know, to gate that, or to, because usually there's only usually like within like a 1 week of the month which you get pregnant. That's when you're ovulating. So if most people don't really know that, then it's kind of hard to gauge that. But once they have the appointment with their reproductive endocrinologist, they usually have a doctor on their team, a nurse on their team, a navigator, which kind of plans everything. And then they also have a financial person on their team. And then the next step after that is usually the diagnostic stage. So they usually have the patient call on their day 3s. So on their day 3s, we check their AMH level, which is basically how much gas you have in the tank. Like we want you to be above 1. If you have like less than 1 level, then that means we know you have a diminished ovarian reserve. And then we check other things like your estrogen, progesterone, your LH, and then your FSH. And then the other 2 tests that we usually do is your saline sono, which is the test that evaluates your cavity. Make sure there's no like things like fibroids, scar tissue, or polyps that would affect implantation. And then we also do the HSG, which I mentioned before, just like the test of your fallopian tubes to make sure that they're patent. But another important test that we have to also do is like on the male part too as well, which is a semen analysis. So they usually do that. And then after that, the diagnosis, they determine like if there's something that's causing the infertility. A lot of the times there's nothing that's causing it. And then we kind of think of like different kind of treatments, which is either like the IVF process, the IUI, or timed intercourse. And we just kind of monitor we have you come back every few days just to kind of monitor your follicle growth. With some patients, we put them on medications just to get the optimal follicle growth or the optimal amounts. And then when it's that time, we also do levels every 2 days. So we check your levels to see if you're producing estrogen, the progesterone, which we want you to do. And then we kind of know when you're going to ovulate, if you're about to ovulate, and then we kind of plan the treatments based around that.
Yeah, and there's a couple things you mentioned. One is PCOS, polycystic ovary syndrome. And I know a lot of people don't even know that they have it.
Yeah.
And
common symptoms of those include like the irregular periods, acne, and excessive hair growth. Most people don't know that they have it. Usually one thing that a doctor suspects that you might have is when you mention that you have irregular periods to them. So that's like kind of the first thing that most people complain about. And that's when they usually do the work up there and kind of find out what's going on. Usually people with PCOS have increased AMH levels. So based off of that, or when you do like a pelvic ultrasound on them, if you take a look at both of their ovaries, they usually have a lot. So like anything greater than 12 follicles, follicles are basically fluid-filled sacs that can carry a potential egg. Usually if they have more than that, then you can get suspicion that they have PCOS. So since there's some treatment for that, especially if you're trying to get pregnant right now, if you're not. So if a person's trying to get pregnant, we got to kind of regulate and see like when they're going to ovulate. So it all depends on that too, because with the person with PCOS, they're so irregular that themselves don't even know when they're going to get a period. So there's kind of things that we look at, like your lining of your uterus, and if it's thick, or like your progesterone levels, we can tell if you're about to ovulate or if you're already ovulated, and we take a look at all those kind of stuff. But usually people with PCOS, like the main issue is that you just don't know when you're ovulating. So we got to kind of time it to that time for you to get pregnant.
Yeah, I can't tell you how many people I've seen with PCOS told they can't even get pregnant. And then
Yeah.
they're sending me for a pregnancy test because they were like, someone told them they're not ovulating. It's just they don't know when.
Exactly.
Yeah. And anyone want to say anything about that?
I'd like to add valid points and very informational what you ladies just stated, but in reference to PCOS, what you were talking about earlier, Lucinda, about obesity, a lot of times PCOS is directly linked with your thyroid health as well due to the insulin level. So majority in my research that I have done on my own of minority women and men who are impacted by infertility and have to proceed with reproductive treatment is due to our nutrition, what we're eating, and that is then leading to PCOS, thyroid levels, and things of that nature. So if we can, like you're saying earlier, when we go to our primary care physician, if the doctor takes that initiative to look at the patient's weight and their overall health, and then take that initiative to say, okay, I know that this can also lead to infertility. Let me talk to you about it in a kind, welcoming manner, not a way to scare you, then that would be very beneficial.
Mhm. Yeah, and I do want to say something on that as far as weight loss, is that with PCOS, it makes it harder to lose weight. And I've had women who tried and their provider is like, you're not exercising enough. You're not eating, they like really making them feel bad. I actually had a patient break down and cry because I explained that to her because she was like, I'm monitoring my diet. I'm going to the gym. She joined a boot camp and she said, it's been so hard. And when I explained to her about the process that her body is going through, she was like, that makes sense. And she was like, no one ever told me that. They just made me feel bad about my weight.
But so just to add on that too, what you were saying, she's working out, she's eating right, but now she feels stressed. And earlier we said that stress can lead to infertility because stress is your cortisol levels that can impact your thyroid, leading to hyperstimulation, hyperthyroidism. I apologize, I said it wrong, but basically your thyroid levels is impacted and now you're unable to conceive. So the doctor think they're addressing the PCOS, but they're causing another issue by stressing her out. So now she still can't get pregnant. So it's a full wellness package that they need to provide.
Yes, yes. Anything else about that? Roseanne, you want to say something.
No, I just wanted to say yes, that all of you have to look at the patient holistically. Even within my practice, when I was practicing at Planned Parenthood, I would always, for the well woman visit, try to address every single issue system-wise with the patient and give them more information, give them literature to read so that it can, spark discussions. If they have questions, they can always come back. And yes, I would start the workup, check in to see if they have PCOS, and then we would refer them out to endocrinology if
Yes,
they did in fact have it.
yes. And what about uterine fibroids? Because that's especially among Black women, and I hear that all the time, that it's some women who don't even realize they have fibroids. They've been having heavy periods all their lives. And then I do their annual, feels like fibroids, or uterus is enlarged, and they had no idea at all. But Thelma, if someone has fibroids, can they come in and have it? Like, are they going to be treated for their fibroids? Like, what happens with that?
So yeah, so with the saline sounders, so because sometimes the fibroids can impact your it could be in the endometrial cavity. It depends on where the location of it is. And if it's there, it's like when you think about it, when you get pregnant, where is it supposed to implant the pregnancy? So that could be something that could be obstructing that pregnancy. So usually after we do that test and we note that there's like something impacting the line, like a fibroid, we usually do a hysteroscopy to kind of remove the fibroids, and then after that, we do another saline sound to make sure that there's nothing impacting it. And then we go from there. But yeah, if it's impacting the line, that's something you'd have to have a procedure for to get rid of.
Okay. And I did have a family member who had fibroids removed, and she was able to get pregnant, and she ended up carrying her pregnancy to term.
Exactly.
Without any issues, because they kind of scared her too. They were like, since you have fibroids removed, you're high risk. And she ended up being okay, but it was it was stressful for her too, but she ended up
Yeah.
doing fine.
Yeah.
Yeah, so we're almost on time, running out of time. So I do want to ask each of you just some final words about anything that you would like, anyone to know who is trying to become pregnant, like what, or just any final thoughts or anything else that you feel should be said. And I'm gonna start with you, Rosie, and I'm gonna just go around from on my screen.
Back to, overall health, diet and exercise. We have to be cognizant that yes, losing weight, if you are overweight, has a impact on your fertility issues as well, and diet. And in my research to it, I learned that Mediterranean diet, staying away from red meat and so forth, certain foods that you do consume can impact your sperm count as well as women fertility issues, and increase your chances of becoming fertile. So sticking to like a Mediterranean diet and getting enough exercise, getting enough sleep, getting enough rest.
Yes, yes. I heard Mediterranean diets are good for stress too. I've been hearing a lot about that. Okay, Trashaunda?
I was just agreeing. Well, my final words are to whoever watches this, you're not alone. As you can see, all of us are here today to advocate on your behalf, to make you feel welcome, to let you know that you're seen and that this matters. We all work in this field in different aspects and doing our due diligence to make it better for you and every other person. And that what you need to focus on is taking it one day at a time, being kind to yourself. Talk kindly to yourself. There's already enough pressure in the world and society and stigmas that can make it worse for you. But one day at a time, and know that speaking freely is what's going to be best for you. When you're with your physicians, don't hold back, because that can just be the opportunity for you to actually get the answer and get the treatment that you need. And we care, and hopefully I hope this message helps you and it brings you closer to wherever you're trying to reach.
Thank you. I love that. Be kind to yourself. Okay, Heather?
And my final thoughts, we've had a lot of juicy gems here, is I would say that, to take charge of your health, to take charge of your visits too. That visit is for you. That visit is not for your provider. And to, like you said, Lucinda, to make sure you're asking a lot of questions and making sure that you're getting the answers to your questions, or at least getting guidance to help with those questions. And also to tag on that stress, that is a big, I think a lot of us do not know how to manage our stress at times. And so for you and your partner, so if there's two of you in a relationship trying to conceive, that for both of you to ensure in good health, you have to be able to manage your stress.
Okay, great. Thank you. Lakisha?
I was gonna go on the same train as Trashaunda with the being gentle with yourself. You are not alone. This is not a rare occurrence. Many, many, many women and men do experience this. So know that there is a community out there that that needs the support of each other first and foremost. And then there is a community of medical professionals or professionals in fertility that is there. Again, don't be afraid to bring this up on your own. You know your body better than anybody else. Go with your gut. If you feel like something is not right, then you be the first to speak up. And to the point of your appointments, don't feel like you have to have, I have a problem visit or something is going on. If you just want to have a conversation about pregnancy, if you want to have a conversation about fertility or about my periods or is there something wrong with my partner? I don't know. You can just call and say, I want to make an appointment to have this conversation, even though you don't know how to, what it may be called when they type in the appointment type. But you just say, I want to have this conversation and I want to make an appointment. And you advocate for yourself for that. And come with the questions, all of the questions. And if they try to cut you off and, oh, we only have 5 minutes, 10 minutes, okay, well, I want to make another appointment to continue this. You have to be your advocate and get your voice heard and get the care that you absolutely deserve. It's out there and you push for it. You're not alone.
Mhm. Thank you. Thank you. Thelma?
I agree with what everyone says. It's very important to ask questions because if you don't ask questions, you never really know, and it helps to get more education on stuff like that so you can actually better understand what's going on with your body and then seek the services that's needed. And also another thing I'd want to say is like, don't be scared to get a workup. If you feel like something is wrong, you can just be like, tell your PCP, I want these labs orders, or like certain tests, you want to check your AMH level. That's like a first thing that you want to do to see like, how your ovarian function is. But yeah, don't be afraid to come in for help. We're all here for you. And a lot of people go through this. I know people think it's like taboo to like, because they want to keep it to themselves because it's like stigma and everything, but you never know, if you don't seek help, how are you going to get the help?
Yes, yes. And I love that because I think that's really, and I agree with what everyone said, you're not alone, take care of yourself. You have the right to have questions answered when you go in for a visit. These are so many important parts of how we take care of ourselves. But I think that there are so many things we don't talk about when I'm not saying the solution is easy, but talking about it can help us learn ways to address what some of the issues are. Like the woman who came in and she disclosed to me that she was worried about infertility and her periods were irregular. And then it turned out she had thyroid disease. So when her thyroid disease was treated, she became pregnant. So it's like, I'm not saying it's always a simple fix, but sometimes there are things that we can look at. And I love what you said is that we know our bodies and we have to start trusting how we feel. If you feel like your periods are not right, I had someone who had heavy periods and she was like, well, some people, her provider said, some people just have heavy periods. That's normal. You've been having these for a long time. And she had fibroids. So anyways, I just say, if you still feel something is wrong, you can see someone else. You can always, like Lakisha said, you can just go in for a consultation. Insurance companies will cover that, and there are some places that will still, if you don't have insurance, well, there's programs that can help you so that you can meet with someone and figure things out. But the resources are there. And again, on the website, I'm going to post some resources. There's some that's already there. We're going to continue to add to it. So just keep an eye out. And we also are going to have a live kitchen table where we talk about this a little bit more and answer some of the questions that you have. But also, if you want to have a kitchen table in your community, you want to have a smaller gathering, you don't want to you don't want to talk in front of a lot of people about questions you have, that's also an option as well. So I want to thank you. I want to thank everyone who came today because I think this is so valuable. And I'm like, where were you all when I was trying to get pregnant? So it's just nice. And I'm just hoping that even if there's one person that's helped, that, again, if there's additional questions, there's resources and places where you can go for support. Okay, so thank you, everyone.